identified problems amongst the children, and reduced and painful mobility, and because of impending skin breakdown or breakdown, scrotal edema, labral edema, this simple day-to-day work is painful. So please keep in mind these things also. And there's significant psychological impact. They have depression, they have anxiety, they have sleep disorders even, which, in addition to ascites and pulmonary congestion. So they have a very poor sleep quality. So keep these things in mind. So nowadays the fashion is that, the stress is that you first try to identify the edema phenotype, whether it is underfill or overfill, and try to manage and tailor your treatment accordingly. So we know the features of hypovolemia. We know if there is abdominal pain. Remember, then this could be due to gut wall edema and ischemia, and don't underplay this complaint. Check for shock. You can very well encounter hypovolemic shock in grossly edematous patients. History of oliguria always helps. In lab parameters, in underfill, this is mostly, everybody knows, this is usually found in hypovolemia. And underfill is associated with very low serum albumin, while overfill, serum albumin is low, but usually above 2. So go for the pattern of findings. And the problem is that most of these parameters become useless because the patients come with prior IV fluid or diuretic therapy, and the parameters become haywire. Other modalities, point of care ultrasound can help you pick up, inferior vena cava feeling, and you can see the collapsibility or the diameter and guess for the underfill or overfill. Bioelectrical impedance analysis is there in academic places, mostly research, but it gives you a good estimate of total body volume. Allergies, we are there with it. Nothing to tell you except that whenever facial edema is present, despite your OPD overload, always check for annual involvement. If facial edema is there, there are chances that there could be an airway involvement and it could be a medical emergency. Turner seat, the dorsum of foot, hand and feet with edema. There are some life-threatening causes, generalized we know, but in localized, again, I'll emphasize that allergic reaction, angioedema with airway involvement has to be promptly treated. Even ACE inhibitor-induced edema, ACE inhibitors are, kininase inhibitors. So whenever you take it, there's a higher level of bradykinin leading to vasodilatation and all the sequences of edema. So localized causes of edema should not be ignored. Workup, initial workup always leads to a better management because you go for a specific workup. In liver diseases, as protein losing enteropathy is becoming more and more, in focus, stool levels of alpha-1 antitrypsin. This is a non-dietary protein. You will never ingest it from somewhere. Your liver will make it, and it is not susceptible to the proteolytic enzymes. So the level of alpha-1 antitrypsin will give you the hint of protein losing enteropathy. Angioedema, rarer, especially hereditary angioedema, you can go for complement level. Management is treat the primary stabilizing hemodynamics and the cardiac output. Mild edema needs no diuretics, but please try to admit these cases. You're admitting it. But what I'll emphasize is that if patients come with skin infection, cellulitis, or impending breakdown, or with lots of discomfort in mobility, please admit them too. It's not only the sick, but the discomfort which has to be addressed. Treatment, diuresis sets in, especially in steroid sensitive. Within a week, proteinuria response by the second week. In OPD cases, don't restrict the sodium, but there's a nice time to pass on the message that fast food nahi de, they are loaded with sodium. Fluid restriction is done only when there is severe refractory edema and steroid resistance is there. Acute unstable cases, you can go for exercise limitation. Otherwise, let the child lead a normal life. So this is an algorithm picked up from Indian Society of Pediatric Nephrology, very popular with us. Hypovolemia, apart from normal saline 10 to 20 ml per kg, we can also use 5% albumin after 2-3 boluses if the things are not improving. 5% albumin over 30 to 60 minutes if there is especially hypotension. Later on, you can give 20% albumin over 3 to 4 hours. Mild edema ho gaya. Moderate and severe edema, when there is more than 7%, start with oral diuretics, but they can be gut edema interfering with the bioavailability of furosemide. So we can, if it is not responding within 2 to 4 hours, shift over to IV so that we bypass the gut. If this is not responding adequately, that is 1 to 2% of weight loss per day, then you can, use the thiazide or thiazide-like diuretics, which will use that sequential nephron blockade to potentiate the action of furosemide. But even if this is resistant, then go for albumin, which will improve the delivery of furosemide, which is tightly bound to albumin in the thick ascending loop of Henle. So this is the workstation where we face off with the disease, and this is the area where the furosemide acts, and it acts on NKCC2, sodium potassium 2 chloride co-transporter. I'm very happy to remember this in full form. This is the DCT where most of the thiazides act. But if you combine furosemide with metolazone, it has its effect also on the proximal convoluted tribune. So we are, catching the sodium on both flanks of furosemide activity. And at times there is compensatory reabsorption in the DCT. I mean, this will be checked by your metolazone. So, diuretic resistance is to be addressed and tackled. So I've discussed this. Diuretic resistance, apart from what I have mentioned, they can be poor salt restriction, and this will increase the load of the diuretic. So, you will not get good results. Hypoalbuminemia also causes problems, and that is why we are combining albumin infusion and furosemide. Similarly, metazoline, if given 30 minutes earlier, ऐसा कोई बहुत reports में नहीं है कि बड़ा effective है, लेकिन fashion अच्छा है, and it makes you look smart. कि give 30 minutes earlier than furosemide. Albumin, remember, when there is hypotension and hypovolemia, go for 5%, give it like you give blood on any, colloid product. But if it is no shock, then go for, 2 to 4 ml per minute, wala 20% DGA for next 3 to 4 hours. Side effects are known. So this is what happens. We are so happy, not exactly happy, but we are always ready to take up the challenges which have been done by my esteemed colleagues on the pediatricians. We admit, and the hypo plus albumin plus metolazone, and so this is ethically correct also, and we have accomplished. The mission is achieved, but sometimes we, in overzealous activity, what has happened is that the poor child went into a dehydrated phase with his sunken eyeballs, and we had to give normal saline. It happens quite commonly. Okay. So apart from diuretics, if nothing is steroid resistance, severe edema, with compromised kidney function, go for ultrafiltration of kidney therapy, a replacement. ACE inhibitors, especially in steroid resistant, and they are hypoproteinuric, decrease the edema, and long-term factors are also playing. In any case, it will help in even reducing long-term proteinuria. Other agents of change, tolvaptan has hardly any trials in, it's an aquaretic, V2RA antagonist, receptor antagonist, vasopressin block karta hai, but no attempt in children. Treatment basics for other diseases, we are always trying to catch that increased capillary hydrostatic pressure due to sodium and water retention, which could be secondary or primary. And we do it by these modalities, which is very common. Never forget the specific treatment. Remember your super specialist friends. Spironolactone and IV albumin is also good. Bas. So coming to my resources, remember, it is all right not to do not require full knowledge of any subject to apply the solutions. You simply have to have a good super specialist friend, give the drugs, and whenever you are in problem, call them up. Thank you. I think I have ended on time, so I'll take this liberty, give some value to my silver and missing hairs, because all the chairpersons are very senior to me, except for Avinash. So I'll take 2 minutes to thank them personally, which I didn't do because of the discipline we showed in following the timeline, right? So Madam Neelam Verma, ma'am, she's pretty senior to me, but I won't mention how senior. But let me tell you, we are very, I was very close to ma'am's husband. जब भी सर पिकअप करने आते थे PMCH में नीलम वर्मा मैम को, तो she used to be busy, but I used to entertain him a lot. And he has nice habits. We had many things to share. Coming to Vinod sir ने बोल ही दिया. हम लोग का एग्रेशन भी बड़ा सिमिलर रहता था, but with time सर वैसे ही रह गए, मेरा ठंडा हो गया. Bhupender sir is like an, elder brother, and Avinash is like a younger one. So sorry, I just extended my time. Thank you.
So thank you, Dr. Jayant Prakash sir. Is there any question or comments from the audience? I think that there is no question. So I'd like to finish this session. Yeah.
You talk about tetrauresis causing
Yes,
water immersion in the nephrotic.
Water immersion used to be tried in adults, but didn't find much support.
In Chandigarh, the nephrology team was coming to pediatric.
In fact, sir, if you, I shared my talk in the souvenir. So water immersion is mentioned in one of the articles. So even it was news to me also. पढ़े तो जाने नहीं तो जानते भी नहीं थे. Thank you.
Water immersion, in fact, is being used by some of the vets to treat chronic kidney failure patients. And probably in olden times, the water immersion has got some scientific basis behind it. It shuts down the ABP levels.
In adults.
And yes, it can produce diuresis in some people.
Exactly. But we have nothing against the quacks. They have also done their service. And you remember my last message, you don't require full knowledge to apply the solutions. Okay. Thank you.
But I think this is not recommended for nephrotic syndrome in children.
No, not nowadays.
Yeah.
Not nowadays. The article Khalash and all, it is very easily available on the net, and you can read the current recommendation. Okay. Chale? Thank you, sir.
So thank you very much.
Thank you, Dr. Jayant, for such a nice deliberation. Yeah, very informative, very interesting. All the aspects of nephrotic syndrome and treating edema. Thank you.
Thank you, Jayant sir, for being on time and sharing your knowledge so beautifully that hardly we had any questions. And we are thankful to our chairpersons who were listening so patiently, and they gave very beautiful comments. So now we are shifting to our next session, and that is to be covered by a person who has come from a place where we get Sandesh. So I'm very sure that she is going to give very good Sandesh about nephrotic syndrome, because we have Dr. Sushmita Banerjee from Kolkata, and she is going to talk about spectrum of childhood nephrotic syndrome, recent guidelines. And for that, to chair, we have Dr. Suraj Kumar Gupta, Senior Consultant Nephrologist at Medanta Hospital, Patna. Then we have Dr. Mukteshwar Rajak. He is Senior Consultant Nephrologist at Bokaro General Hospital. We have Dr. Sushil Pathak from our place. He is assistant professor at Nalanda Medical College. And we also have Dr. Anil Kumar from our place. He is HOD at Bettia Medical College. So I request all the chairpersons to come to the dais and introduce the speaker so that we can proceed in the manner we did the previous session. So thank you.
Good afternoon, everybody. I'm very much thankful to the organizing secretary, Hemant Kumar sir and Om Kumar sir for inviting me. And the scientific session is very fantastic and very meticulously is being organized. And now this is the second topic of this session, and topic is very, very interesting to the general physician, nephrologist, as well as the pediatrician. That is the spectrum of the nephrotic syndrome and the current guidelines. Now over to the speaker, Dr. Susmita Banerjee, already introduced by Dr. Madhu, and over to Dr. Banerjee. Thank you.
Thank you. So I will start with a very big thank you to Dr. Hemant Kumar and the local organizing team. I think this is a really excellent idea of organizing this crosstalk between nephrologists and pediatricians. And we, the pediatric nephrologists here, are really thankful and happy to be here with you all. The local hospitality and arrangements have really been excellent till now. So I will start with my talk, which is describing to you the recent guidelines on pediatric nephrotic syndrome. So we all know that that nephrotic syndrome is one of the commonest chronic long-term relapsing diseases in children.